Thank you, Sanjay, and thank you all. It's wonderful to be here. As Sanjay said, I do want to just give an outline of what cardiac MRI can offer in the evaluation of the athlete. A number of the slides will highlight pathology, but highlighting pathology where, I suppose, the diagnosis was difficult to achieve without the use of MRI. So one of the challenges and the role of CMR is that many conditions responsible for sudden death are silent. Many don't have symptoms, and indeed the specificity of the pre-participation questionnaire can be poor, in that the manifestation of these conditions in athletes can be sudden death as the first manifestation. And then where do we go for the athlete who has a distinctly abnormal ECG? I'm sure that the comments from the back of the room ring true for many people here. How comfortable are we with the grossly abnormal ECG to reassure the individual based on potentially a normal echo? We have to be concerned about tests after tests after tests, again, increasing patient and family anxiety, potentially giving inconclusive results, and indeed of cost. So this is a small paper done from the west of Ireland by a colleague and friend of mine, Emer Joyce, presented last year at the ESC, essentially demonstrating the positive answers. Patient or individuals completing the pre-participation questionnaire and demonstrating, answering the question yes to many of the questions. Yes, I've had some palpitations. I've had some chest tightness during sport. And what do we do with those individuals? When all the answers are no, including family history, we are reassured somewhat. But when the answers are yes to some of the questions, what do we do? So these are ECGs in individuals who have normal echocardiograms. So the ECGs are abnormal. But what do we do? And then what about those with a normal ECG? Martin and Marin's group published this year for this false negative rate in patients with confirmed hypertrophic cardiomyopathy who are undergoing ECGs. And this is an ECG of a patient who has confirmed hypertrophic cardiomyopathy, which is, I think in everyone's opinion, would be considered normal. Another MR confirmed a diagnosis of hypertrophic cardiomyopathy, again in an individual with a normal ECG. The prevalence being anywhere in most studies between 5 and 10%. So while we react with regard to added screening tests for the individual with the abnormal ECG, there are, again, a small cohort who have conditions with a normal ECG. And we always have to remember throughout the 2 days that the evaluation of the adolescent, the elite, the moderate athlete, the veteran athlete differs owing to the different causes or the dominant causes of sudden cardiac death. Again, if we think about the veteran athlete, typically that's due to coronary artery disease as opposed to some of the inherited cardiomyopathies. So some of the clinical scenarios that we deal with day in, day out is the individual who has suspicious symptoms, but the investigations are equivocal or non-diagnostic. Then we have the individual with the distinctly abnormal ECG and the, open inverted commas, normal echocardiogram. Are we sure that the echocardiogram is normal? Have we adequately seen the right ventricle? Or have we adequately seen the basal anteroseptal wall or indeed the apex of the left ventricle? Then there's the athlete who presents to the emergency room with, inverted commas, an acute coronary syndrome. They've had typical or atypical chest pain, but they're found to be troponin positive. What do we do with those individuals? And then there are the unknowns, some of the conditions or the abnormalities that we are now visualizing using a cardiac MRI that we don't quite understand the significance of. Sorry if I'm just looking to my right. There's a great video playing on this screen. Not quite sure what it is. Cardiac MRI, why do we use it? Well, it's non-invasive. It involves no radiation. So it's the ideal imaging modality to serially follow up individuals, to look for subtle changes. Has the subtle increase in left ventricular wall thickness regressed with the detraining? And as well as just looking at wall thickness, structure and function, we can evaluate valves, shunts, congenital abnormalities. Abbas's talk mentioned very nicely this morning about the use of CT to look for anomalous coronaries. In a 12-second breath hold, we can do the same thing with an MRI. So we're not adding to the length of the scan. It is a simple and straightforward addition. We can look for microvascular disease. Again, a finding which is more indicative of abnormality than normality. And obviously the holy grail of cardiac MRI focused around the use of gadolinium contrast. So gadolinium contrast is given intravenously. It's an extravascular agent, and it localizes in areas where the connections between the myocytes are changed in some way, either because there's edema and cell swelling, so it highlights into those areas, such as acute myocarditis, or indeed in areas of fibrosis or scar or infarction. So these are just some of the sequences which we can do with an MRI. So you can see if the top left of the screen, that's a standard cine image. That's an 8 to 10 second breath hold. You can bring it down to 3 or 4 seconds if you wish. And again, wide field of view, easy to image both the right ventricle and the left ventricular apex. Some of the diastology can be assessed using MR tagging techniques. One of the nice additions is the MR perfusion. Now, MR perfusion now has moved beyond giving a 4-minute intravenous infusion of adenosine through a second peripheral line with a long line from the scanner into the control room. We now go in and give a medication called regadenoson. So that gives maximum hyperemia in about 20 seconds. It's a single IV push over 15 seconds. So again, it is simplifying the whole process. So again, it's making perfusion much more accessible and straightforward to do, with less of the adenosine-induced side effects such as flushing, chest pain, or indeed asthma. So again, here, if we look at this is the base of the heart. This is the left ventricle. Actually, I think I may have a pointer here, yeah. This is the left ventricle up here. And we can see this very dark area here. I hope it projects well. And that is an area of hypoperfusion, and this is in the inferior infraseptal and infralateral wall. And this is in a patient who had an incidental finding of an abnormal ECG, completely asymptomatic, and this is due to a silent occlusion of his right coronary artery. And again, this is much more important, most likely in the evaluation of the older athlete than indeed in the younger athlete. This is one of these simple 10 to 15 second breath holds to look for the origin and the course of the proximal coronary arteries. We are not going to diagnose obstructive coronary disease with regard to looking at the lumen, looking at early atheroma, 20 to 30% stenoses. Perfusion is a functional test, and this is just to look for where are the coronary arteries coming off. This is gadolinium enhancement, which we've mentioned. This is flows, again, for congenital shunts. These are T2 weighted or STIR images. And again, very nice to look for acute myocardial edema. So why is it particularly useful? You will see this slide or a similar slide of this kind shown many times over the next 2 days. The causes of sudden cardiac death. Well, MR is able to look for all of these in a single 25 to 35-minute scan setting. So it's particularly useful in that regard. And again, some very nice work from Mary Shepherd's group, looking at the etiology of sudden cardiac death in athletes in the UK. And there was these concerning findings of idiopathic left ventricular hypertrophy at autopsy, hypertrophic cardiomyopathy, or diffuse interstitial fibrosis. Again, conditions which we don't quite understand very well. Interstitial fibrosis is quite interesting. And again, we can now image that in using cardiac MRI, using this T1 mapping technique. And this is some nice work from James Moon's group and Andy Flett, looking at the different signals of T1 mapping in both normals and indeed in pathology. However, we don't quite know what to do with these techniques in athletes. Is there a normal progression of interstitial fibrosis in athletes, especially as they move on to being veteran athletes? So we have to define what is normal in the athlete, both young and old, before we know what to potentially do with some of these novel techniques. And again, you can see that it's not an easy curve to differentiate, apart from if you have cardiac amyloidosis or infarct, you get these very high T1 mapping signals. But again, in other areas of pathology, again, there could be a bit of an overlap. So it's coming down the line. It is very, very interesting, but I'm not sure the data is yet there for how it's going to be used in the evaluation of the athlete. There's a BJSM publication coming out fairly soon on kind of aspects, all aspects of the evaluation of the athlete. This is a paper that we've written just looking at imaging fibrosis, both macroscopic fibrosis using the late gadolinium enhanced technique, and then interstitial fibrosis using the T1 mapping technique in athletes with left ventricular hypertrophy, and how it may be used. So there is some tables there in that paper which is coming out which may be of use. So again, as part of the crash course, I just wanted to link to just a standard MRI of a patient that I recently saw. High-level professional footballer, completely asymptomatic, negative family history, denies steroid use, but had undergone screening with a colleague of mine and referred him for based on this ECG, referred him for a cardiac MRI. So you can see here he's got infralateral T-wave inversion. He's a Caucasian athlete. It is not particularly deep T-wave inversion. But again, I'm sure everyone here, like me, would say, well, it's abnormal. It warrants further investigation. He also had, these charts that we have for cardiac MRI, again, done on a normal population. And typically, in an athlete, this is the end diastolic volume. This is the end systolic volume. And typically, you will see that these bullet points here for the age will be high for athletes. So they'll normally have high indexed volumes. They will have a low resting ejection fraction, and their left ventricular mass can be increased. In this individual, he has low normal indexed volumes. He has a hyperdynamic systolic function, and he's quite a very marked increase in mass. So I'll just show you his scan very quickly. And again, it's quite useful with regard to just showing the standard MRI. So this is a standard MRI. These are just some of the early scout image. You can see very muscular individual. These are the pectoralis major and minor there. And again, just going through, we're seeing the arch of the aorta here. This is the SVC down into the right atrium, just following the black arrow there. This is the IVC coming up. So we're seeing the interatrial septum just here. Here's the pulmonary vein. So we're seeing the right upper pulmonary vein, the right lower pulmonary vein, the left lower pulmonary vein, and the left upper pulmonary vein. So again, looking very, very quickly, this is a 10-second breath hold. We're looking very quickly, immediately, is the congenital anatomy normal? Here, obviously, we can see you can actually see the origin of the right coronary artery there quite nicely, coming off, and the left coronary artery we'll see in a short while. We can look at the main pulmonary artery and the right pulmonary artery and the left pulmonary arterial dimensions. Very easy, we can measure those. Look for any obviously abnormalities in the lungs, in the chest wall, and again, we're just looking at the left ventricle here and the right ventricle. And again, these are some of the coronal shots. Again, I won't focus on them too much, but each of these, remember, are 10-second breath holds. Again, looking at there's the pulmonary arteries left and right, there's the airways, and there's the heart coming into view, there's the IVC. So moving on to the cine images, again, these 6 to 7 breath holds. This is the 2-chamber view. That's the 4-chamber view. We can see this individual's quite generous concentric hypertrophy, and again looks a little suspicious, particularly in a Caucasian athlete. Now we see the apex very nicely here, and very clearly it's quite obvious. So again, looking for apical hypertrophic cardiomyopathy. Looking at his right ventricle, again, I would say that right ventricle appears to be mildly hypertrophied. Contracting well, but mildly hypertrophied. And again, the apex here almost looks just a little bit suspicious. So when we do I tend to do a transaxial cine stack, so we can just line them all up there like that. And this is right from the top of the chest, right down to the bottom, base to apex. And again, with some of the newer softwares, it's extremely easy to review all images very quickly. So there's the right ventricle at the top, the left ventricle here. This is a standard cine stack which is required for the full evaluation of the right ventricle to outrule MR features of ARVC. These are some of the T1 weighted imaging. Again, not particularly useful with regard to ARVC, but quite useful with regard to looking for the origin and the course of the proximal coronary arteries. And again, then we move to the dedicated the views to look for the peak wall thickness in all segments of the myocardium. So again, these are typically 6 millimeter slices. There's about a 2 millimeter gap in between each slice. So again, excellent coverage of the entire myocardium. I'll flick through these. These are some of the gadolinium-enhanced images. But again, nicely, you're looking for evidence of myocardial scarring or fibrosis. I think that's window, just doesn't quite window as well on the projector. But again, looking for myocardial fibrosis in the myocardium, which would light up quite bright and white. So that's kind of a quick run through with regard to what a standard MRI, a non-perfusion MRI is, that we've looked for the left ventricle, the right ventricle. We look at the pericardium, congenital shunts, congenital abnormalities. We're looking for fat in the LV or the RV, although recognizing that that could be a relatively non-specific finding on MR. We're looking for contrast or evidence of prior myocarditis, silent infarction, or indeed mid-wall scar, which is indicative of pathology. And that all can be achieved in about 20 minutes. So moving on, this individual detrained for 3 months. So again, remembering his initial ECG with infralateral T-wave inversion and an MR which wasn't jumping out as being hypertrophic cardiomyopathy, but it was a little suspicious. But that's his ECG now that he's detrained, and the lateral T-wave inversions have now resolved. He continues to have some inferior T-wave inversion in 3 and AVF. And I must say, his repeat MR looks an awful lot better. So hesitantly, I'm calling him normal, but I'm certainly going to keep a close eye on him. But again, the lateral T-wave inversions, this is a Caucasian athlete, and again, we can't definitively outrule perhaps performance-enhancing drug use. This is the more typical athlete, where high index volumes, as I said, low normal resting systolic function, the stroke volume is very high, and the mass index is typically high. Stefan Peterson did some work with regard to looking at some of these ratios. I won't focus on them now. The table will be available on the online slides. So why is it important to use MR? Because there are many, many papers looking at the reproducibility of echo measurements with regard to serial changes in small changes in wall thickness or cavity dimensions, with issues with regard to the inter-study and intra-study reproducibility and the inter-observer reproducibility. So and again, MR won't be for everybody, but if you have that difficult case and you want to truly assess what is the response to detraining, I would say MR is certainly the way to go. A couple of examples now. High-level triathlete. Palpitations and frequent bigeminy and trigeminy. Echo is completely normal. No coronary disease. And the question is, what is it? Is this a veteran athlete who has an increased tendency towards ventricular and atrial arrhythmia owing to being a veteran athlete? Well, MR confirms that the structure and the function of the heart is normal, but when we give contrast enhancement, we see mid-wall fibrosis here in the lateral wall, and that's consistent with the diagnosis of prior myocarditis. So again, establishing the diagnosis, I think, is critically important in this individual. What it means for that individual, we don't know. This is a 32-year-old male, denies possibly used anabolic steroids, but he's a combined weightlifter and endurance athlete. And he was admitted with a troponin-positive event. And again, normal coronary angiogram, interestingly minor LAD disease in a 32-year-old actually, but deemed not to be the culprit and not to have caused any issues. Other than that, things were normal, but when we give him contrast, we see areas of infarction in both the LAD and in the infralateral wall, most likely the circumflex artery territory. You see it quite nicely there. This is the papillary muscles, and you see that bright white stripe, not sparing the subendocardium, consistent with myocardial infarction, and in his case, most likely either a spontaneously recanalized thrombus in the left coronary artery or a thromboembolic event which went down the left coronary artery and went right and left, one into the LAD and one into the circumflex artery. 39-year-old, chest pain, abnormal ECG, elevated troponin, normal coronary angiogram. So these are some of the STIR images. So you don't have to give contrast intravenously for the STIR images. These are looking for water, myocardial edema, inflammation. And this is the anterior wall, and we see this whole anterior and septal wall brightening up very nicely. And once we give contrast, it's very easy. This is a transmural infarction in the LAD territory. Remember, people can have infarcts in the absence of angiographic coronary disease. And again, these are rare events, but you can see one event is an infarct. Other events can be myocarditis, both having normal coronaries. coronary angiograms. Lifelong, veteran athlete, 57. Out of hospital, VF arrest, resuscitated, normal angiogram, comes in, normal echocardiogram, mild troponin elevation, thought perhaps to be due to CPR and cardiac resuscitation. So what's the advice for this 57-year-old athlete? Does he get a defibrillator implantation? Well, when he goes into the MR scanner, his heart is, this is a bit stretched, apologies, it does look quite abnormal. But his heart is structurally normal, but when we do the cines and we do the STIR imaging, we do the GAD imaging, we see a focal area of transmural myocardial inflammation or edema in the inferior infralateral wall, corresponding with this area of transmural infarction. So he's had a small infarct. He's quite unlucky, age 57, to have an infarct, but also for it to cause a VF arrest. But these things happen. But again, in this case, the data would say not to put in an ICD in. You have to wait a period of time because it's related to an acute infarct. So again, we can take the exact same clinical scenario. 39-year-old, chest pain, elevated troponin, normal coronary angiogram, presents through the ED. Here's the cine image. And again, that looks pretty normal. But when we do the STIR imaging, we see this entire lateral wall lighting up. And when we do the contrast, we see this large region of contrast uptake in the epicardial wall, sparing the subendocardium. So this is a diagnosis of myocarditis. So two very similar cases. One is a transmural infarction. The other is a focal infarction with a primary arrhythmic event. And this is myocarditis. All had similar presentations and all had normal coronary angiograms. Matt Wilson and a number of us here looked at veteran athletes, lifelong veteran athletes, asymptomatic, and we put them through the MR scanner, and we said, well, are we seeing anything? And in 50% of them, now there was only 12, but in 50% of them, we found areas of fibrosis. So it comes back to the question earlier with regard to finding the focal fibrosis in the lifelong athlete. What does it mean? Well, in these individuals, it's hard to know what it means, especially if you find insertion point fibrosis, this non-specific fibrosis relating to the interdigitation of the myocardial fibers at the LV-RV junctions, where instead of being kind of nice and parallel, they are interdigitated abnormally. And obviously, with high levels of activity and physiological hypertrophy, you may get insertion point fibrosis, which usually wouldn't be as prominent as Abbas's nice case earlier on, but you can get it in RVH, in hypertensive hearts, but we haven't found it to be a normal finding in physiological hypertrophied hearts, but perhaps that's because there's not enough data there, especially in veteran athletes. But you do find it, and the question, we don't quite know what it means. So in the evaluation of hypertrophy, there are many differential diagnoses. For hypertrophic cardiomyopathy, the diagnosis is better made with MRI because we can visualize this basal anteroseptal wall, the posterior wall, and indeed the apex in a far more efficient way. And this relates to some of the unanswered questions. Abnormal ECG in this individual, completely asymptomatic, and I hope it's just gone off the screen there, but you see these very prominent cleft-like formations, really right down through the anterior wall. Doesn't to you there, over here. And I don't know what that means. Clefts have been shown in one or two studies to be more common in genotype positive, phenotype negative hypertrophic cardiomyopathy patients. Philip Kilner, however, has also found them to be present in normal individuals, although perhaps individuals that haven't been genotyped. This is, to me, is certainly a cardiomyopathy, but it's a as yet undefined cardiomyopathy, for which I can not advise the individual because I have no data to do so. In this individual, while we are concerned about costs of extra tests, this individual for me would require Holter monitoring, exercise treadmill testing in order to help us somewhat refine his risk. Now in some individuals, gadolinium, contrast, fibrosis will be the only abnormality that you see. This is an individual with the family history, and I think they've, can we just change the screen resolution, please? I think you're just losing the left-hand side. 35-year-old female with a family history, normal ECG and a normal echo. Normal wall thickness, thank you. but diffuse myocardial fibrosis in the myocardium. Clearly a pathological process. I'm happy that we've established that fibrosis is likely, should be contributing to the risk factor evaluation for sudden death. It's not an all or nothing. The amount is important, but also it should be in the context of other known risk factors. In genotype carriers who have, again, completely normal echocardiograms, you can find myocardial contrast uptake, you can find myocardial scarring fibrosis when everything else looks normal. So it is actually quite important. And in this paper, since genotype carriers also display structural abnormalities and focal scar, they are suggesting that we should be looking potentially in genotype carriers at them with cardiac MR to define whether or not there is an abnormal myocardial process going on, as opposed to just relying on wall thickness measurements and diastology with echo. 26-year-old European boxer, with a Caucasian European boxer, very abnormal ECG with T-wave inversion from V2 to V5 and left ventricular hypertrophy. Echo is normal, but this is a very subtle case, and one that I spent some time over, but I believe there is a very subtle sliver of apical disproportionate thickening in this case, and I'm happy, based on the ECG, to label him as mild phenotypical apical hypertrophic cardiomyopathy. I have not put any restrictions on the individual to continue to compete. And for the purposes of time, I'll move on just to some of the remainder, the last few slides. So this is a case report that Matt Wilson, Sanjay, myself, and Michael published last year with regard to the finding of cardiomyopathies in elite athletes. And let us always remember that the two are compatible. I hear far too often from colleagues who kind of say, well, it's unlikely that this individual would have run a 3.5-hour marathon if they had a cardiomyopathy. The two entities are compatible, and while we focus an awful lot on the abnormalities on echo, the strain abnormalities, the diastolic dysfunction, that's not present in everybody. So that they are compatible, the two. How do we risk stratify patients with hypertrophic cardiomyopathy? This is a gentleman who has a single risk factor of unexplained syncope. Would we put in a defibrillator? Well, this is hopefully an answer to your question from earlier. Pretty extensive patchy midwall fibrosis in the maximally hypertrophied area. So he has a single risk factor, but now he has fibrosis. We say he probably has two, so we'll put in a defibrillator, and this defibrillator has discharged appropriately, I think, a month or two after implantation. So probably the right decision was made. This is a 61-year-old male. He's got HCM diagnosed since age 49. Now, I'm sure there's people here, again, similar to maybe some of my, not my colleagues, but things that you hear is that, well, he's 61. He's probably beyond that high-risk time of his life. Asymptomatic annual serial follow-up, 22-millimeter septum, and some LVOTO at rest. Should we put in an ICD based on his single minor risk factor? Well, he's got extensive myocardial fibrosis, so I would say now he has two, and that's how he presented to A&E. So he now has a defibrillator in situ. And again, what we see, the structure and the function of the heart by echo or MRI doesn't tell you what's happening in the myocardium itself. So these are two similar-aged patients, both moderate-level exercisers, asymptomatic, both have hypertrophic cardiomyopathy, both have similar wall thickness measurements. But the patient on the top left has essentially minimal myocardial fibrosis. The patient on the bottom right has lots of myocardial fibrosis. So what appears to be the same condition is two very different conditions in those two individuals. We and others have validated that what we're seeing on an MRI scan is representative of SCAR when we see gadolinium uptake. And what does it mean? Well, a couple of years ago we published the prognostic significance of SCAR in hypertrophic cardiomyopathy, and it is telling us something. It's not giving us the whole picture, but I believe it is contributing. It is helping us. So if you want to really define how aggressive or non-aggressive the HCM phenotype is, I believe an MRI is essential. It does correlate with major adverse cardiac events over time. This is at 1, 2, and 3 years, and over here is the amount of scar. So the more scar that you have, the higher the event rate, but obviously there's not a huge number of patients who have the largest amount of scar. Well, what else can we do? Well, this is a moderate level exerciser who had a cardiac arrest, a normal coronary angiogram. He has hypertrophic cardiomyopathy, but he has a lot of microvascular abnormalities. So this is the rest perfusion scan. So these are all normal. This is abnormal during adenosine. So again, I believe that the diffuse microvascular disease is contributing to our understanding of what is happening for that individual. I won't spend much time on dilated cardiomyopathy, apart to say that 1/3 have mid-wall fibrosis, which you do not see in athletes with a dilated heart, and that is one of the strongest, if not the strongest, predictor of outcome. And that's based on work from Sanjay Prasad's in the Brompton, as well as Ankur Gulati with Sanjay, which won the Young Investigator this year at SCMR. Other challenges in the athletes with MRI relate to non-compaction versus increased trabeculation seen in the physiologically remodeled left ventricle. The answers aren't there yet because we are seeing hypertrabeculation now more so than ever owing to the superior spatial resolution of MRI. So just finally, for the right ventricle, I just thought the right ventricle, if we want, we can look at all evidence of scarring of fibrosis in the right ventricle, diagnostic of ARVC. But one of the nice papers published in this publication relating to which is the athlete, well, in the athlete, they will tend to get symmetrical increase in chamber dimensions of both the left and the right. But in this ARVC case, the left ventricle has not remodeled, but the right ventricle has disproportionately remodeled, which is an abnormality. So I think I'll leave it there, only to say just at the end, the very nice work in the Bruder registry of 11,000 patients demonstrated that if you did MRI, in 86% of cases, you did not require any further imaging. In 16% of cases, the diagnosis on MRI was different to that before MRI, and in nearly 2/3 of patients having had an MRI, the management changed. Thank you very much.